Starting. All attendees are in listen-only mode.
Good evening, this is Dr. McSherry. It is June 17, 2014 at 8:06 p.m. Tonight we're going to be doing caseless instruction and critique. I'm waiting for my faculty to come on board. I think they're a little busy tonight with maybe ectopics or deliveries. And until then, I am going to be doing the caseless construction. So I see that we have a couple of candidates here tonight. And I do have several caseless to look at. So I see that Dr. Karagouli's here, and I'll go ahead and pull up her case list. And I'm just going to pull it up via, Ben, I'll take you off of mute. Hi, Ben, how are you?
Hello?
Yep, I hear you.
Oh, are you calling on me? I'm sorry.
Yeah, that's all right. I think I have you here. And do you want to do, which cases would you like to do?
I would like to do office.
Office. Okay, that's not a problem.
We're not getting a mock oral. We're just being criticized.
No, just critiqued on your list. You're not ready for a mock oral now, are you?
No.
No, I wouldn't do that to you tonight. Okay, just bear with me. I'm doing a little multitasking because I have a couple of faculty that are wanting to come in and help. So I'm just trying to text them at the same time I'm talking to you. So just bear with me for a second. Dr. Walton was going to come on board, but she had something going on tonight with a patient, so I couldn't get her to get on board. But I'm waiting for Prusak, and Dr. Modi's also coming, and I have a couple other candidates. Can you turn your volume down? Are you on an iPad or a Mac?
No, I'm on the laptop. Wait, let me put the...
There's a little bit of feedback coming
Is this
back.
better?
That's better, probably. Okay, good. Okay, let me just send her a chat. Okay, I really have to send her an invitation again. Okay, so just to go to your office list here, let me make it a little bit bigger. All right. Are you doing okay with the software? You know, having any problems putting your lists together?
I use Exam Pro.
Yeah, I know, but you're not having any problems with it, are you? You're doing okay?
I did at the beginning, but I fixed it. I know how to use it.
Okay, now, okay, good. Yeah, because, you know, it gets, in the beginning, it's frustrating to try to figure out how you can fix things, and they do prompt you to put some extra stuff in, and it can be a little annoying sometimes. So, okay, so starting with case number 1, I see we have irregular periods. I would do irregular menses.
Okay.
You know, you don't want to do layman terms.
Okay.
Because you got hirsutism here. Why don't you just put hairy patient? You know what I mean?
Okay.
Okay.
Agreed.
That's the first thing I had thought on there. So irregular menses, and then hirsutism and obesity. That's perfect. And then history and physical exam. Now, I just want to let you know, like here you have and then here you have this and here.
Which one is better?
It doesn't really make a difference.
But have it to be the same.
1 second. All right, just hopefully he'll stop barking. Okay, 1 second. I have a dog and a carrier, and I just wanted so he wouldn't bother me tonight.
Oh.
I know, it gets a little annoying after a while.
What kind of dog is that?
They're Malteses. They're 2 little white fluff balls, but I don't know why he's barking. He's just usually I put him in the other.
He doesn't like my voice.
Yeah, I guess. Hang on 1 second. Let me just put it in the other room. Okay, you're in the other room now. I don't know what he could possibly be barking at. There's nothing. He's looking at a wall. Okay. I had him in a carrier, so he would be quiet. Okay, so anyway, to get back here, so and here, I would just
Right.
do and. Now, a lot of candidates are not putting history and physical exam this year because that's kind of a no-brainer. We all know you're doing that. But, I mean, you've put it on all of your list already, so I don't think there's a problem about maybe deleting it. You can just keep it there. But some people are doing it, some people aren't. So just a little food for thought. Okay, so anyway, history, diagnostic test, public health. You can get rid of diagnostic tests because you're already putting pelvic ultrasound there.
Right. But
Right,
I did
so-
blood work for PCOS, so that's why I put that there.
Oh, okay. So you want to do, you maybe want to put down screening tests for polycystic ovarian syndrome and let them ask you, say, hey, what are your screening tests for polycystic ovarian? And then you could tell them that.
Okay.
Or you could. I mean, diagnostic tests. And if you're going to put diagnostic tests, then I would just omit pelvic ultrasound because that's part of your diagnostic testing. Do you see what I mean?
Yes.
So either be really vague or be specific. It's up to you. It seems like in the bulletin they want you to be specific, but in past years we've always told people to be less is more because
Yes.
you want those questions. You know what I mean?
Right.
So it's up to you. It's up to you. I mean, there's no wrong way to list. You just don't want to list too much stuff. Okay, so you have counseling here, oral contraceptive pills, and metformin, and that's fine. I think I would leave that the way it is. I think it's good. And then you have ongoing care. That's perfect. Did she get better or did she get worse?
She's getting better. I haven't seen her. I saw her a month ago, but
Do you want to say symptoms
see.
improved?
sure, yeah.
Yeah,
Yes.
that might be a little bit better to
Yeah.
put. So
Yes. Absolutely.
okay, now somebody just texted me and said, how about putting down, instead of irregular menses, put oligomenorrhea?
I thought they were trending away from those terms. As in the bulletin, it says to no longer use menorrhagia and mitrorrhagia, and just put heavy bleeding and intermenstrual bleeding. So I just didn't want to use oligomenorrhea because I didn't know if that was still an ongoing thing or not.
Yeah, that's fine. I think that irregular periods, or you can put abnormal uterine bleeding.
Right. Yeah, I can change that.
Yeah, if you want to. Okay, number 2, postcoital bleeding, that's fine. A history and physical exam, again, remember the and. Diagnostic tests, again, you're being non-specific and then you're being specific. So try to stick with one thing. Endometrial biopsy benign, pelvic ultrasound normal. That's perfect. Now, if you're going to do that with this, make sure you do pelvic ultrasound, what your ultrasound was with the case number 1.
What it showed.
Right. You want to be consistent. Okay, counseling, removal of cervical I would put polypectomy.
Okay.
Okay.
Because I didn't take her to the OR. I did it in the office. So
That's
that's why
fine.
I
That's
read it that
fine.
way. Yeah.
That's fine. Polypectomy. And then, because that was a treatment, right?
Right.
Yeah. And then pathology benign. You already listed that under endometrial biopsy, so you don't need to list it twice.
Oh, well, that's the pathology of the cervical polyp that I removed.
Oh,
It's
okay.
not the
So
pathology
you
of
can
my
write
many-
polypectomy benign.
Right.
Okay.
Yes.
And then symptoms improved.
Right.
Okay.
Okay.
Be consistent. Okay. Case number 3, postpartum breastfeeding. That's fine. Breast redness and tenderness.
So here I put the diagnosis.
I would put
under his-
mastalgia. I would put mastalgia and erythema of the breast.
Instead of breast redness and tenderness?
You know, I wonder if that's kind of non-specific there. You know, postpartum breastfeeding. Okay, then leave it. Just leave it. History and physical exam, and then I would put breast exam. I would put your findings and then put mastitis. But that's fine
Findings,
too. I guess
yeah.
you could do it either way. I think either way is fine.
Right.
Yeah. I would just leave it. Just leave it, Van. I wouldn't go crazy
Okay.
here. Antibiotics, that's fine. And then put symptoms improved. Did it go away totally?
Yeah, after a week, I saw her again, was gone.
Okay, so yeah, symptoms resolved or, yeah, that's perfect. That's fine. Okay, number 4, desires contraceptive STD screen, that's fine. That's fine. That's fine. I would put contraception implant.
Okay.
Because Nexplanon, I think, is a brand name.
Yes, it is.
Or etronorgestrel implant.
Okay.
Okay. Case number 5, desires emergency contraception, history and physical exam, copper IUD insertion, that's fine. No pregnancy. That's fine. I'm trying to think how else you could word that. Yeah, I think that's fine. Pregnancy test negative.
Or I can say not pregnant. I just, I don't know. It looks a little bit odd. I
I know
agree.
it does.
Yeah.
Let me think about that one. Let me think about it. Okay, number 6, postpartum depression, crying episodes, unable to take care of baby, history and physical, counseling.
I should
Okay,
probably write that there's no suicidal ideation, right?
that's fine. You could do that. Okay, yeah, okay. Somebody just sent a text out regarding your cases. I'll let you read it. All right. That's fine.
As text to your cell phone?
No, text, text, oh yeah.
You can trick her with AUB. Oh, okay. Here's the one unnecessary text.
Yeah, it's up to you. I mean, that's just a comment. It's just a comment.
Okay.
Okay,
Right.
number 7, annual exam. That's good. 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 7's fine. I'd leave it. Perfect.
Okay.
8, dysmenorrhea. That's fine. Dysmenorrhea ultrasound. Okay. Why did you order a pelvic ultrasound on the 34-year-old? What were you worried about here?
Adenomyosis, fibroids. I wasn't sure why.
Did your physical exam reveal anything that made you concerned that you needed to order an ultrasound?
I remember that her exam was like her uterus was a little bit bulky, but it actually ended up being a normal uterus on the ultrasound, so she didn't have anything.
Do you think it was an unnecessary test?
Probably. I mean, I felt like I didn't want to miss anything. I was like, she's 34, now she's having dysmenorrhea. She hasn't had it before. Probably there's something going on in her uterus. And that's why I did that. But, I mean, you're right.
I would put pelvic exam, uterus enlarged.
Okay.
Yeah, I'm getting a text message again about your case list, so I'll send it to you. Okay. It seems to me that it's just a little, kind of like ordering something because you didn't know what was going on. Why not just treat her first, and then if things don't get better, then order the pelvic ultrasound. So I would just put history and physical exam, counseling, non-steroidal, and then improve. I wouldn't put the pelvic ultrasound there.
Okay.
Okay. Number 9, menorrhagia. Remember you said you wanted to get away from that term? Put abnormal uterine bleeding.
Yes. I should have taken.
Yeah. Heat and cold intolerance. Did she have hot flashes?
No. No hot flashes.
Okay. Fatigue. Oh, that's fine. I would get rid of the diagnostic test and just put elevated TSH.
Okay.
All right. Levothyroxine improved. So she had hypothyroidism, obviously, right?
Right.
Okay. Perfect. Beautiful. Number 10, annual exam. History of breast and ovarian cancer. History and physical, age-appropriate screening tests. Okay, that's fine. Counseling, BRCA testing. Okay, they're going to be really specific with this. What was going on with the family history? Did her mom have cancer, her sister had cancer, or what's going on?
Yeah, her mother and her aunt and her sister.
Oh, yeah, okay, that's fine. Was her BRCA testing positive?
You know what? I don't think she did it. I think her insurance didn't pay for it. I have to follow up on her because.
Why don't you follow up on her, because BRCA testing actually would go under diagnostic procedures. It wouldn't be going under treatment because it's not a treatment. See what I mean?
Okay. Okay.
So find out what's going on with this case.
Yeah.
All right.
I didn't get the result of the tests, but
Yeah,
I
you
know
need to.
that her copay was high, so I wasn't sure if she eventually did it or not.
Yeah. Okay. Cool. All right. 11. Annual exam, DEXA scan. Oh, wow. -3. Boy, that poor lady.
Right.
Was she referred to you from somebody?
No, she just came in for an annual, and I
Okay.
ordered a DEXA.
All right. Okay. Okay. Was the annual exam? Oh, right. Was a T-score part of her annual exam?
No, that was a follow-up
Okay.
afterwards.
Counsel. All right. Somebody sent me a text again. Okay. All right. I'm sending you another one. You can just read them on your own. All right. Just somebody just giving you some tips. Okay. Okay. History and physical, age appropriate screen. Okay, that's fine. Okay, you put her on a.
Whoever's giving those remarks seems as if they did the exam before.
Yeah, they've have some familiarity with the exam from before. Yeah, they do.
Right. So thank you for whoever's writing the notes.
Yeah,
I'll
that's
read them.
Shelley. Shelley's doing that for me. She's kind of helping me out tonight.
Yeah, thanks.
Yeah, she's been there, done that. Okay, so she's kind of listening in tonight. All right, so counseling, lifestyle modification. I mean, Shelley, if you want to participate, I mean, let me just pull her over.
Okay.
I'll pull her over because she's just listening in tonight.
She's
Shelley,
just done with the exam?
Yeah.
Okay.
Shelley, I pulled you over if you want to make a comment here and there. So you're on the faculty sign, so you may want to put your headset on.
Okay.
Let me know when you're ready. I'm going to mute you in the meantime. Okay, I'm muting her until she's set up. And then just text me on my cell phone when you're ready. Okay, so let me close this out. Yeah, she sent me a lot of, I let her make comments here and there if she wants. She's been there, done that. Okay, yeah. So anyway, with 11, now did you think something else was going on? I mean, why was she such a low T-score?
I have no idea. She was somebody who came for the first time, not my patient. And I just ordered a DEXA, and that was the follow-up afterwards when I called her back and I said, hey, come back, let's talk about this. And
where was the score the lowest at? Was it the spine or the hip?
I'm not sure. I have
You
to
need
go
to know
look at it again.
You need to look at that, yeah, because they may ask you. Because bisphosphonates, like, raloxifene versus bisphosphonate, I think bisphosphonates are better for the hip, and then raloxifene's better for the spine. So they may be a little bit specific on you. I would probably not be specific, and I would say T-score osteoporosis. I wouldn't be that specific. It sounds better to put osteoporosis, don't you think?
Sure.
Yeah, because then they might get into, she's got secondary causes for, they could go into, hyperparathyroidism, multiple myeloma. That's a really low. I haven't seen a T-score that low before, personally,
Right. Hello?
I'm just trying to fix my microphone.
Yeah,
Just
okay.
slapped for a second down. I'm just trying to fix it with I have a clip that holds it up because it's the thing here. Okay, there we go. Now it's better. Sorry about that.
No,
Okay. Okay, Shelly, I'll take you off now. Okay, Shelly, you there?
Yes, can you hear me?
Yeah, I can hear you fine. So,
Can you hear me?
yeah, I can hear
Okay.
you. Can you hear me?
Yes.
Okay, so we were just talking about case 11, and I thought that maybe T-score, maybe she should put osteopenia or this is osteoporosis,
it's
obviously.
osteoporosis.
Yeah, so
Yeah, I
would,
agree, because then it gives them the opportunity to ask her how she found it and how she excluded secondary, if, you know, and then they can ask her about fracks, like, you know what I mean? It gives them an opportunity to ask her.
But
Okay.
they're probably going to ask me what the score is, right? Or would they not?
No, I don't
No?
think so. They may ask you definitions, right, Shelley?
Exactly. They'll ask you definitions, and you can say, as Dr. Wall would say, you give them the range of what's normal and what's abnormal,
Okay.
because you will know that.
Okay. And thank you for the notes. I was just reading
Yeah,
them.
no problem, no problem.
Okay.
Yeah.
So
Okay,
you think I should only put positive things?
You want to only give them the results that were reflecting a result that was abnormal.
Right.
Okay? Because you don't want them to know that you did tests that were unnecessary.
Okay.
Because there might be some things that might change in terms of recommendations
Right.
that will become obvious on the exam that you shouldn't have done at that time.
Right. Okay.
Okay, so anything that might change then becomes an issue on the exam, and you don't want that to be the case.
Okay. You're right.
Okay. Shelley, you want to make a comment about 12?
Let's see, secondary amenorrhea, galactorrhea. That one actually looks pretty good because she put the pertinent positives, and
I would put,
Should I put
I would
the
put
number?
hyperprolactinemia. I wouldn't
Yeah,
put,
the number was very high. I just
Yeah,
thought
I
it was
would-
interesting.
hyperprolactinemia would be the diagnosis. Galactorrhea is a symptom. That actually sounds more appropriate.
But they already know that I'm talking about hyperprolactinemia,
No, they-
right? Because it's the
prolactin
category.
elevated? Prolactin
Galactor-
elevated?
Well, see, the galactorrhea is more of a physical exam finding too.
Oh, okay.
You see, so that would be, you know, a physical exam finding.
Okay.
So I
all right,
would
I'll
put
take
that-
off.
Yeah, I mean, if you're gonna keep your history and physical exam on all your diagnostic procedures.
Do you
right?
think I should take them off?
You can. When I put mine on, they were. I had physical. You know, I had history and physical exam, and then any pertinent positives on the history and physical exam, I put a little dash and I put the positives on it.
Okay.
So I would put, you know, history and physical exam dash galactorrhea.
Right. Does that go for mastitis when I was putting the breast disease?
Yeah, because those are all things that she didn't tell you I have galactorrhea. You can't. She doesn't come in
Right.
and tell you I have galactorrhea.
Right.
So,
Okay.
Yeah, she has breast leakage or breast discharge. You know. And then for brain MRI, I would put MRI macroadenoma. I wouldn't put the size.
Okay.
You know, and then
yes.
refer to neurosurgery. I wouldn't put initiation. No, I would just put bromocriptine.
Okay.
Right, Shelley?
Right.
Yeah.
Right. Just
Okay.
put bromocriptine. Keep it real simple. But for yourself, keep these notes, these original notes. Know what the cutoffs are, and then you can remember that it's 15 millimeters because you'll shine on the exam if you say 15 millimeters. But what's normal, or you know what's abnormal, anything above 10 millimeters.
Right.
So they don't even get into that much detail.
They
at all.
don't?
No.
They won't ask me specifics about my case list. They'll just go into the topic and start questioning me?
Pretty much. I mean, I was asked about a Turner's patient. So, and they don't get into the detail. And then they move on to the next question.
Okay.
Yeah.
Okay. Oh, Shelley, Laurel,
Yeah.
are you there?
Yeah.
Hey, Shelley, I want to thank you for filling
No
in for
problem.
Laurel in the
No
meantime. It
problem.
was awesome. Thank you,
Okay,
Shelley.
no problem.
I
No problem.
appreciate it.
No problem.
Okay, Laurel, do you want to take over? We're on.
Oh, I can. I didn't think I was on tonight. I have on my list I'm on tomorrow night, but that's
Yeah,
fine.
I actually asked you when we were on last time. I said, Laura, would you help me on Tuesday? And you go, oh,
Yeah, I said if I could, but
no.
Tuesdays aren't very good for me.
I know, and I knew they weren't, but you said there was no problem. I thought maybe your schedule had changed.
No, I was doing deliveries.
Oh, are you okay? Are you okay now? I mean, if you're busy,
No, I'm sure fine.
you're fine.
Hi,
Okay.
Dr. Walton.
Oh,
Hi, how are you?
Good.
okay. Dr. Walton, we're on we're on case number 14. If you want to keep on going,
Okay, we're just going through them, kind of
just critique.
critique. Okay, all right.
We skipped 13. Do you think 13 is
Oh
okay?
yeah, okay, 13. Yeah, I'm sorry.
Okay.
Yeah, number 13, Dr. Walton.
Okay, I do mine a little different than what I heard when I came on, and I'm not saying one way is different than the other. I'm just saying it's food for thought. When I do a case list review where you have history and physical, I just say history and physical, and then I put down diagnostic tests. I don't give them the answers to anything except those things that are wrong.
I had
Or
diagnostic
abnormal.
tests, a lot of them, but yeah.
Yeah, I don't give the, unless they're abnormal, I wouldn't write down a TSH. Now, some like to do that, and there's nothing wrong with that. There's nothing wrong with what you did. I will tell you guys, unless you're better than I am, I would be putting down the units. Now, some say not to put down the units, but I would put down the units because they'll ask you the units. When you give them a test value, you should know the units.
Units of what, like the prolactin? And okay, yeah, I don't know those.
Or the TSH is, I think it's units UTI. I can't remember them. I have to look them
Yeah.
up myself because I'm so used to looking on a form, and I don't have anything in front of me tonight. But that's just food for thought. And then I would put down, I always write down counseling, but I guess you don't have to in the third line. I always write counseling and, you know, discontinue the medication, and then problem resolved, I think is fine.
Okay. Should I be
Immunization.
specific on the medication and stuff, like for the ranitidine, or should I just write, you know?
I think you could either write discontinuation of medication and they'll ask you what, or you can use it as you have it.
Okay. Okay.
Immunizations, again. Do we have to write down antenatal screening test in that? 29 weeks, I would have thought you had all your antenatal screening tests done by 29
Yes.
weeks.
Yes.
What immunization, are you just referring to the DTaP vaccine?
Yes.
Yeah. Yeah. When do you give that shot, by the way?
Give it after 27 weeks.
Okay. Yeah, and is it given every pregnancy?
Yes, it is.
Yeah, the only problem with that is when you get past 2, remember there can be a sensitivity to it, and some are having some reactions like anaphylactic, so just be prepared. Not telling you guys not to tell them you give it because they're recommending, ACOG's are recommending it with each pregnancy after 27 weeks, not after the lady's delivered, although some of us have to give it then because they haven't had it before, but they're trying to protect the kid.
If she had it after the delivery and then she got pregnant the year after, does she still have to get it again?
Yes.
Okay.
That's what they're recommending.
But
Now,
you're saying that they could have anaphylaxis?
if they get it a number of times, depending on how many children they have.
Okay.
Okay, so antenatal screening test, I don't know what you mean by that. I probably wouldn't have that on there. If you did some testing.
No, I just meant the OB labs and the stuff. This patient came in like at 28, 27 weeks, so I just had her, so I just thought I would put it in there just to fill in the space, I guess. I could take it off.
Yeah, I probably wouldn't leave it on there. I don't think it's needed.
Okay.
If they ask you about testing, they would ask you regardless of what age they see you
Right.
see her. Yeah.
Okay.
Counseling. See when you see some of these you counsel, some you don't. So I don't know. You know, I try to get in a pattern of doing everything the same way.
So should I put counseling for everybody?
I don't know, Denise. Are you telling them to do that? I tell them if it's office or
Right.
an OB patient, I tell them counseling is great.
Right. I mean, Laurel, I think I think that's fine. Absolutely.
Okay.
Yeah, I think counseling, age-appropriate counseling, and Shelley just texted me, age-appropriate counseling is good if you're doing an annual exam, or if you're counseling a teenager or a 65-year-old and, regarding, STDs and so on. But I think that's appropriate, definitely.
Mm-hmm.
Yeah. I mean, Laura, what do you think again? I mean, what do you think is the best?
Well, I think that, what ACOG's trying to get past with us, is that, and they've stressed it so much, that and even those of you guys that are taking the DO board don't have to do a case list. I'm going to tell you, haven't been in both shoes, they still are going to ask you everything that you want to know about counseling. So I think, whether you put it on there or don't, they're going to ask you. Does it decrease your anxiety that you put it there and you're thinking about it? Well, for me it does. So, I think it's a give or take. But I want to fill something in there, but I guess you don't have to. I like it. So it's just how you make your own case list.
Okay.
Okay? Okay, I think that's fine. Case number 15. Sexually transmitted disease, is that screening? Do we have to spell it out, or can it be abbreviated? I don't know the new bulletin. STD screening. Can you write it
STD's
that
okay.
way?
Yeah.
Okay.
Yes,
Yeah, it's fine. Mm-hmm.
I think I'd write desires contraception.
Okay. Not desiring, desires. Okay.
History and physical exam, that's fine if you want to write it all out. Diagnostic test, vaginal
So does
cultures.
the cultures and like the ultrasounds go under diagnostic tests, or are they separate? But because
No.
what I mean, diagnostic tests, I usually mean blood work. But
That's what I do too,
okay.
because I think of diagnostic tests as something that I get blood work on, and if I was thinking ultrasound, I'd write ultrasound or x-ray.
Okay.
Okay, and vaginal cultures. Okay, counseling, oral contraceptive pills, HPV vaccine. Okay. Do I have to wait to start somebody on oral contraceptive pills or any form of contraception before I give a vaccine? Do I have to get in my test back?
No.
I'm just testing you. I'm going here. Okay. Case number 16. Hirsutism, irregular periods. Well, I don't think you need to write primary infertility for 2 years.
Okay.
And the
What
reason
would I
I say
write?
that is she's gravid at 0-0.
Okay.
Now, you can, I mean, they may ask you why you wrote that down, and this is a patient who wants to get pregnant. You put it under the infertility evaluation and management. So I don't think you need to write that.
Right. You're right.
History of physical exam, diagnostic tests, semen analysis may come under that, or as you wrote it, it can be that way. Again, I don't write all my tests unless the tests are negative,
Okay.
because I want them to ask me something.
Right.
Because they'll ask you what other tests you did. But if that's what you did, that's fine. Did you do any more under your, what did you do under your, what's your thinking under diagnostic tests? What did you do?
I did blood tests and hormone levels on her, TSH and FSH and
Okay.
all
So
that
you want to be
stuff.
consistent, because if you go back up to 13, which is just barely on my view, you wrote a TSH as normal.
Right.
Would I do a TSH on this patient? Absolutely.
Right.
So you want to get in a habit, if you're going to write down your tests, it gets too wordy to have them all on. My words of advice are only write those things that are abnormal. When they ask you, say, additional tests that I did included the following, but they were all normal. Now, they still can ask you what's normal on any of these for anybody. But just get in a pattern. So if you're going to write normal up here and you wrote it all out, then you're going to have to put it down. You have to have consistency because they'll ask you why you did one place and not the other.
Okay.
Okay, pelvic ultrasound, fine. Counseling, prenatal vitamins. Was this a heavy patient?
No.
Okay, because sometimes you want to put in there, you know, things about weight and exercise if they're young, that you've tried those things too. Okay.
Yeah. She had PCOS, so.
Well, that's why I thought she might have been a heavier lady.
She
I know I
wasn't very
shouldn't
heavy,
assume
yeah.
that. I shouldn't assume that. But it does follow.
Right, yeah.
Okay, 17.
Same thing.
Okay, his
Primary.
infertility, again, I would just say infertility. I know it's primary.
Right. I was looking at this actually today because I was editing this list today, and those two cases seemed to me like they're the same. And I was debating removing one of them and putting something else in another category. They're the same, aren't they?
You could do that or leave it and see if they ask you different questions. I mean,
Because the first one had PCOS, the other one I found no reason for her why she wasn't getting pregnant, and I just gave her Clomid, and I'm still following up on her. But the one with the PCOS actually got pregnant and delivered earlier in the year. So they seem different to me, but looking
well,
at them,
this
I
one
did the
could
same
be
thing.
not her problem, could be the guy's problem.
Yeah, but his analysis was normal. Semen analysis was normal.
Yeah, I don't want you guys to lie. What sometimes we say, see, I looking at that, I would say, okay, the semen analysis was abnormal. She's got it on there. She didn't give me any diagnostic tests. And, oh, we moved on. Didn't give me any diagnostic tests.
Just fixing it for you
And
here.
so I guess it must have been a semen analysis. Pelvic ultrasounds as a whole, most of us write them down whether they're positive or negative, you know. Now, on the previous one, did you do an HSG? I forgot.
I did not.
Okay, they might ask you why you did one on one and not on the other.
Yeah, she refused. She wouldn't do it. When I explained the test to her, she refused. So we didn't do it.
Okay. And other questions they'll ask is when do you do these testings? So again, they will ask you why you did an HSG on one and not on the other. Well, the other one got pregnant before you had to go to that step, maybe.
Right.
I mean, we don't do invasive tests first. We do them last. Why? They cost more money, and they're not cost effective if you don't need to do them.
Right.
But again, if you did any tests that are normal, you're just going to tell them the tests I did are such, such, such. They were all normal. But you got a semen analysis on there, and me just looking at this could have thought, well, that's what was abnormal, so now she's going to tell me about that. We had her on Clomid, and now what do we do for the guy so that there's a semen analysis appropriate?
Right.
And then in your results, what are you going to put in your results?
I'm still seeing her, so it says
Ongoing
care
evaluation
upstairs.
or ongoing care?
Yeah, it's cut off on the page before.
Okay. Oh, there it is,
Yeah.
ongoing care. Okay.
Yeah.
Piece number 18, postpartum visit, multi-period desiring long-term contraceptive. I don't think you need to have the multi-period desiring long-term contraception.
Okay.
Well, I know she's multiparous. She's a Gravida 3 para too.
Right.
So I would just say postpartum visit, and then you can write contraception if you want.
Okay.
Okay. History and physical exam. I don't think you need any testing. Counseling and Mirena IUD insertion. Do you put it in that same visit?
Yes, I put it in that visit, and then she came in for a checkup afterwards, 6 weeks after.
Okay. Yeah, some are putting it in right when they deliver now, or even with the cesarean section, believe it or not. Okay.
Yeah. We don't have to do cultures before putting it right. I usually do the cultures the same time I put it in, and then call her if she has an infection.
Now, that's a good question. Do you do cultures on a 26-year-old?
Yes, I do.
Is that what
I do
ACOG
it on
says to do?
everybody. ACOG says below 25, right? Sexually active
Right.
women under 25.
Right.
Um,
So I would not do cultures on the 26-year-old.
Okay.
You
Unless,
can do it. I'm not telling you to change your practice. I'm just telling you for the board. You're not
I
going to
know
say
what you're saying. Yeah.
because it's 25.
Right.
Okay. Number 19, 27-year-old gravida-4, para 3.
Same
I
thing.
would just say contraception.
Okay.
Again, I know she's multiparous.
Right.
And you don't need to say long-term because you're just going to talk about contraception in general. And whatever she chooses, you're still going to have to do counseling of every type of contraception there is. This is a well-chosen area is contraception and contraception in general. So I would just say contraception, history and physical. If you had to do any diagnostic tests on her or not, I don't know. Again, she's 27. You do not have to do cultures on her. Counseling and Paragard IUD insertion.
Do I need to change the Mirena into levonorgestrel and the Paragard into copper, or am I good with putting their names like that?
Either way, whichever you feel most comfortable with. Some are saying to write down, you know, if it's a contraception, that would be an oral contraceptive pill and you can't remember what's in it. Some people will write it down so they remember what's in it. Like, for instance, if you gave her Micronor, Micronor is progesterone only.
Right.
So some people will write down, you know, progesterone and leave it. Then they get asked about it. The Mirena, the questions they're going to ask you about Mirena are who you use it on, who you don't. Can somebody who's had, you know, unprotected sex and you think she's pregnant, can you put a Mirena in?
Yeah,
Who can't you use the Mirena on? Who can you use it on age-wise? They'll ask you all those questions. So to me, it matters not. You just want to make it for your case list what you feel most comfortable with. I'm okay with either way.
Okay.
If you write it as a Mirena, they'll ask you what's in it.
Right.
Okay? All right. And you do have to have at least 2 visits minimum when you put an IUD in. Some of us would say 3 visits.
As in one counseling, one she comes back to put the IUD in, one to check for it?
Uh-huh.
Okay.
Okay. Case number 20, 32-year-old gravida 3, para 3, birth 1, cyst abscess. History and physical. Did you do any, well,
I just examined her and saw it there, so I didn't do anything other than examining her.
okay. The most common thing that comes out of those is what?
Question-wise or what? Oh.
Staph.
Oh. Okay,
But
yeah.
I'm wondering, if you opened and drained it, do you have to put her on antibiotics?
No, not necessarily.
Mm-hmm. So I'm wondering if you shouldn't have done a culture.
Yeah, I did. I usually send one. I don't remember on her. I have to go look at her chart again, see if I actually did send one
because
or not.
the studies are showing us that if we don't have cellulitis, that we don't need to put them on antibiotics unless it's indicated with cellulitis or an elevated temp or something. Now, you may have had that on your physical. I don't know. You may have had treatment, but I don't know that.
Yeah, no, I
You
didn't
may have to
that.
tell me that. But if you see that, I still would have done a culture.
Right. You do it routinely, but you don't put them on antibiotics and you wait for the culture?
No. If I have one of these and there's no temperature, it's just an area that she comes in and it's a little bit sore when she touches it or wipes, and you do an IND on it and put a catheter in it and keep it open to drain, unless she has evidence of an infection, cellulitis, streaking, temperature, induration, you don't put them on antibiotics.
And do you culture them routinely, or you only culture them if you're suspicious?
I usually do culture them.
Okay. Because
usually who I see with this is older, and you know, when they're greater than 40, I have a little higher suspicion of a problem.
Right.
Okay. Number 21, 15-year-old gravid 0, period 0. Initiating gynecologic care, sexually active. Again, I don't like desiring. I hate that terminology. I would say desires contraception. I don't think you have to say sexually active on this particularly. If you feel comfortable with it, fine, but I would just say gynecologic care, or, you know, I don't even think you have to say initiating it. Looks like Denise is.
Okay, so tell me again what you thought I should change. The safe sex
I would just say,
counseling and all that.
you know,
Age-appropriate
gynecologic or
counseling.
gynecologic care, and I would leave it like that. Do you have to put sexually active? You can if you want. I would not need that because I'm going to be
Unnecessary.
talking to her about it in my counseling.
Okay, so the counseling should be just counseling without specifying what kind of
Yes.
counseling? Okay.
Yes. Counseling in general,
age-appropriate.
you would
Age-appropriate counseling.
talk about every single one of those
Okay.
things in your counseling.
Okay, and then the initiation of oral contraceptives, I should take that off too, or just put
Yeah,
oral
and just write
contraceptive?
contraception.
Oh, okay.
Then you can tell them what you used, or a contraceptive pill if you want to.
Okay. Okay, got it. Thank you.
Uh-huh.
Okay, we're going to move on to another case list,
But
Laurel.
you know, it doesn't look bad, though.
Yeah, she's got a good list.
I thought I had it going good, but you know, now after talking to you, there's a lot I need to work on. And this is very helpful. Thank you very much.
Mm-hmm.
Okay, Rachel's next, and we'll work with Rachel for a little bit. And we don't have a written webinar tonight, so that's a treat. I don't have to work until 11 o'clock. Hi, Rachel. How are you?
Great. How are you, Dr. McSherry?
Good, good. And thank you for being here. I did have several candidates that were scheduled for tonight, but I think everybody was kind of busy. So
Thank you.
yeah,
Thank you
not
for
a
having me.
problem. Yeah, I thought you were on here. Let's see. Let me close it out and me open it back up again.
Yeah, I sent it on your AOL account.
Okay, let's open it back up and see if it's there. Sometimes it needs to reboot itself. There it goes. There you go.
There I am.
Wonderful. Okay. Okay, so you wanted Dr. Walton to look at your GYN, is that correct?
Please. Yes, thank
Okay.
you. Please.
Yeah,
I realize all of us do these case lists a little different. You want to find the pattern that you like. We're just giving you suggestions that we know for
Right.
us have been helpful, and you're trying to get the words down as little as possible. Little as possible.
yeah.
Okay. So case number 1 under laparotomy. Ruptured ectopic, hemoperitoneum, and anemia. Well, first of all, I don't think you need all the words there, because if you have a ruptured ectopic, I'm assuming that you have blood because you opened her.
Right.
Again, I would have just said an ectopic and let them ask you about it instead of saying ruptured.
Okay.
And I would have said ectopic, and I probably would have said anemia. I wouldn't have ruptured in there or hemoperitoneum.
Okay.
And then in the second column, I would have said a laparotomy, and they're going to say, well, why did you do that? You're going to say, well, she had a low iron count, or she was anemic, found she was unstable, her vitals were unstable, and my choice was to do a laparotomy and found a hemoperitoneum because that's what you found.
Yes.
And your pathology then was fallopian tube with an immature. Is that off, or am I reading that wrong? What do you have in your third column?
Fallopian tube with immature placental villi.
Oh, that goes there. Okay.
Yeah. Now, Dr. Walton, would you not put then self-injectony, or yes?
If I did a self-injectomy, I'd put it. Yeah.
Okay. Okay. Yeah.
Laparotomy, self-injectomy, and evacuation of hemoperitoneum. Sure, that's
Excellent.
fine for me. That path report, I would question you what they mean by that. That's,
Okay.
I'm sure that's a pathology report that you got.
Correct.
Uh-huh.
What would you put? What would you put?
I think that's okay. You have to have villi that you see, or you have to have clinical evidence, so that's okay. And then you gave her a blood transfusion?
Correct.
Okay. That's fine. That's a complicating factor, so again, they love to pick up on complicating factors, so I would know about blood transfusions. when you give them what makes your decision, how much they have to lose to get how many units, that kind of thing.
Sure.
Case number 2, 37-year-old gravida 2, para 2, dysmenorrhea, fibroid uterus, heavy excessive menses. You could have written symptomatic leiomyoma.
Okay.
Uteri or symptomatic, leiomyoma. But if you want to write them all again, if you only write symptomatic leiomyoma uteri, they're going to ask you then, well, what do you mean by that? Then you get to go into dysmenorrhea. They'll ask you what's the definition of dysmenorrhea. What do you mean by heavy menses?
Okay, good.
So I would just leave it symptomatic leiomyoma uteri. And then you did, I think you can abbreviate this LAVH. I don't have the abbreviations in front of me, so I have to take it that you guys know them. I do not have this year's. I think you can abbreviate. Is that correct,
Yes.
Denise?
Yeah.
Bilateral self-injectomy.
Yes, and then I just looking down about the heavy excessive menses, I would put abnormal uterine bleeding.
Yep.
Okay.
Because that's
Yeah,
a new
I-
term.
I-
You have to know.
Yeah, I don't know if you guys, I was just answering some text messages on questions, so I'm sorry about
Yeah, that's good. Yeah, either if you have a fibroid, I'd write leiomyoma to uteri, symptomatic leiomyoma uteri. If you just have, like on your second case, number 3, heavy excessive menses dysmenorrhea, I would write abnormal uterine bleeding dysmenorrhea.
Okay.
And then again, LAVH cystoscopy. Why'd you do the cystoscopy?
We did this. Well, I'm a junior person in my call group, and I was with a senior OBGYN, and every single hysterectomy, that's his thing. He does a cystoscopy.
Oh, I don't think it's bad, but my question why you did it is you didn't do it on the first one.
Right, because I did the first one with another person. The two of us did the first one, and he asked me at the end of the second one if he could do the cystoscopy because he does it on all the hysterectomies. So I said sure. But I mean, I did it. But he said, "Could we please do a cystoscopy?" Should I not put that then since it wasn't my idea?
Well, if you didn't do it, I wouldn't put it. But if you're
Well,
going to
I
have
mean-
one with it and one without it, they're going to ask you, well, what makes your decision to do it on one and not the other? Do you think you got in the bladder on one and not with the other?
There was a little bit. There was some suspicion on that second one. Yes.
I would either tell you, my words of wisdom is I'd either do it on all of them or I wouldn't do it on any of them. And
Okay.
personally, a laparoscopically assisted vaginal hysterectomy, I do it on all mine.
Oh, okay.
So it's just your choice, but I'm just telling you, it never hurts to do one. And that's not to say you weren't good at what you were doing, but what has the highest rate of getting into the bladder is not a vaginal hysterectomy, but a laparoscopic assisted has a high rate as well as robotic or, of course, opening. So again, I do it on all mine. Maybe that's just because it's I've done all the abdominal and vaginal longer than I have done the laparoscopically assisted or robotic. Okay. Uterus, 123 grams. Leiomyoma. I would have said leiomyomas. I don't think I would even put bilateral tubes with paratubal cyst. I would have just said fallopian tubes benign, but because those are benign findings. That's common. That's a normal finding unless you want to talk about paratubal cyst. And what remnant is that? Is that of the Wolffian or Mullerian?
Mullerian.
Okay. But they could get into a discussion on development if they chose to.
Okay.
I would put fallopian tubes benign myself.
Okay. Would you leave the leiomyomas under the uterus?
Yeah,
Okay.
I would.
Okay.
Yeah. And I like the fact that I can tell that you got 3 thoughts there because you start each one with a capital letter, which I appreciate. Thank you very much. Okay. But I would just say fallopian, bilateral fallopian tubes benign. Mm-hmm.
Okay.
Okay. 3, we talked about abnormal uterine bleeding and dysmenorrhea, and
Yep.
then and then she's put down endometrium benign, and I agree with that.
Okay.
All right. Number 4. Oh, moving. Okay, number 4, 37-year-old gravida 6, para 4, ectopic pregnancy, a laparoscopic self-injectomy. I think that's fine. That's fine.
Okay.
I usually only capitalize just because I'm anal fixed, okay? Here, perfection is to an end. Okay, I only capitalize the first letter of my statement when it's a new one.
Okay.
And then they know it's a new statement.
Okay.
See what I mean? See if you want to carry it all the way through. I'm just,
sure, no
like
problem.
I said, a little bit perplexed. It's a whole word, then the whole statement for me. Okay. Case number 5. 46-year-old gravida 2, period 2. Again, I would say abnormal uterine bleeding. Because remember, this is the palm colon that you guys have to know.
Right.
Everything is abnormal uterine bleeding, and they could ask this year what little abbreviation would you put at the bottom of them, whether it's a leiomyoma or whatever. Dysmenorrhea, hysteroscopy, DNC, and endometrial ablation. Okay.
What does that say? Polyps 5?
I don't know
No,
what you mean.
polyps. So you listed endometrial
polyps.
polyps down here, so why not list the same thing up here?
Yeah.
Okay.
You know what I mean?
Thank
Just be
Thank you.
consistent. You know what I
Thank you.
mean? Yeah.
Okay.
I'm just trying to help out a little
Yes,
bit.
thank
Now I'm gonna tell you, be prepared by saying that you found endometrial polyps, though. And how do you know that they're benign when you're in there and you do a DNC and hysteroscopy, and then you're going to do an endometrial ablation right after you did it? You don't know with those polyps if they were benign, though.
I use on these patients. I always do an EMV in the office before I do that. Would that count as an explanation or no?
That would count, but that would count. But again, do you get all your polyps out when you do an endometrial sampling in your office?
Not at all.
It's a touchy situation, and the only reason I tell you that is it got thrown at me.
Oh, okay.
And it made me feel uncomfortable because again, do you send it and get a pathology report? Absolutely not. We don't do a send for a frozen section on a DNC.
Right.
So again, second letter in the lines, I would make them small cased.
Sure.
Okay. But I agree. I would put the same thing that Denise said. One place is the other. Endometrial polyps. Yeah.
Okay.
Or I would say endometrial polyps benign and leave it as that because that's all you found. You don't have to say the endometrium is benign. You found polyps and they were benign and they were in the endometrium, so it's redundant to me.
Okay, so cross that out.
Case number 6. Again, I don't know. Can they use abbreviation AUB, Denise, or does it have to be spelled out?
I think you can, but it doesn't matter really.
You want to use the same thing if you're
Right. You want to use it. Be consistent. Right.
Be consistent. Yeah.
I think I looked these up, the abbreviations, and I think abnormal uterine bleeding is not an approved abbreviation, so that's why I wrote it out.
Okay,
that's
that's
fine.
perfect.
That's what you want to do up there. Okay. We're saying it kind of in reference to anybody listening as well. Okay. Sure. I would have said complex endometrium is what I would have said.
Okay.
It doesn't matter whether it's thick or thin. If it's complex, it's a problem.
Okay.
And don't use the word fibroid. It's not scientific. You want to write leiomyoma. So abnormal uterine bleeding, complex. If it was complex hyperplasia, I usually write complex hyperplasia and leiomyoma. Then your operative hysteroscopy, polypectomy, and DNC, and then your pathology report, endometrial polyps, and that's all I would write.
Okay.
Again, remember, if you guys write proliferative and secretory endometrium on anything, be prepared that they'll ask you all about it.
Okay. Then
When does that occur? What day? I would rather just say I had benign endometrial polyps.
Me too. Okay. So put benign there as well?
You don't have to. No.
Okay.
Just endometrial polyps is fine. They're benign if they ask you.
Yes. Okay.
Okay. Because you would have put something down as a cancer if it wasn't.
If they weren't, sure.
Case number 7, 48-year-old gravida 2, period 2, abnormal uterine bleeding, polypectomy, DNC, and endometrial ablation. Boy, I get a little nervous for you on those.
Really? Oh, should I not put endometrial ablation?
I mean, if you did it, you're going to say it, but you could say that. I guess all else fails that you put this in here. It's one patient, and you did this. The results came back. She continued to bleed, and you did a polypectomy.
Okay.
I know you had done your biopsy in the office, like you told me.
Right.
But you're going to have to be really firm on what you did, so that they know that you knew that it was benign. Now, let's say that you didn't do it, and it came back cancerous, and you did an endometrial ablation. They will ask you what you would do if that were the case.
Okay.
Okay. All right. Okay. Let's see. I got some stuff on my screen trying to get around it. Okay, we're on number 8, right?
Correct, yes.
Okay, abnormal uterine bleeding. I take it you had the endometrial polyps on your endometrial biopsy.
Correct.
Okay. Now, the other thing you could do, but again, on these that you have the ablation on, I'm back still thinking about those. You could have wrote over here in your first column endometrial sampling or endometrial biopsy so that they know you did it already.
Okay.
And that way they'll still ask you, but at least it'll keep it in your mind to remember to say it.
Oh, good.
Okay.
Should I say EMB, endometrial biopsy benign, or just say endometrial biopsy?
I just say endometrial biopsy.
Okay, thank you.
Okay, 8, hysteroscopy, DNC, polypectomy, and endometrial ablation. Okay, endometrial polyps, I would have said, and leave it.
Would you repeat that? I'm sorry.
Number 8, abnormal uterine bleeding, endometrial polyps, hysteroscopy, DNC, polypectomy, and endometrial ablation.
Okay.
And then under my surgical path, I would have just said endometrial polyps. I would have followed it just like the other.
Okay, excellent. Thank you. Sorry to make you repeat that.
No, that's okay. I don't think you have to put all that other. It's all benign. To me, it's a normal routine path report.
Sure, thank you.
Okay. We'll get her to up it.
Yep. Now, Marcia, I'm sorry, Laurel. One of the candidates just texted me, and they said, do you need to put the ultrasound reports? And what do you think about that?
No, not unless they're, I put the ultrasound, I tell people to put the ultrasound down only, you mean in this on this particular case list?
Yeah, on the case list in general. No.
No.
I don't think so. And then the proliferative endometrium needs to, with breakdown, and I think you mentioned it already, I would just put benign.
You can put benign, or if they've got polyps like this young lady does, I would just put down endometrial polyps. Otherwise, that's the only finding you had. Everything else was benign.
Yeah,
so I think it's redundant to put it. But if you have no path report except benign endometrium, you'd write benign endometrium.
Right.
In case number 9, you want to write leiomyoma uteri.
Oh, right.
And then you did a myomectomy, and then you just say uterus. Again, like you did up above, you want to follow. You want to write the uterus, 990 grams, and you want to say leiomyoma.
Okay, so, yeah.
That should be 2 lines.
Okay.
Uterus, 998 grams. Second line, leiomyoma.
Okay.
Case number 10, 54-year-old gravid, 0, parent 0, postmenopausal bleeding, leiomyoma to uteri, and polyp. Because I now know you did a biopsy in your office. Hysteroscopy, DNC. I want to read it from one side to the other. Hysteroscopy, DNC, resection. I don't like fibroid, remember.
Yep.
Is that the correct term, resection? I guess it might be resection, leiomyoma, and polypectomy. Okay. And then endometrial polyp.
Gotcha.
And submucosal leiomyoma. Okay. Case number 11, 35-year-old gravid, 6'4". I don't like desire for permanent sterilization, so I probably would have wrote...
request?
Pardon me?
Request sterilization?
I probably would have wrote sterilization.
Yeah, that's fine too.
Okay.
let them ask you. Then they can say, well, she's had 6 pregnancies and 4 kids. She wants it. She desires it. It's her family planning. Or you could have even wrote family planning under there instead of sterilization.
Okay. What do you think is better?
Either one, sterilization or family planning. I will clue you in. I had a gal recently that I took to the hospital, and her insurance wouldn't pay it because I said she wanted sterilization. They wouldn't accept it. They wouldn't pay for it. But when I said family planning, they pay for it.
Wow.
Oh, you know, come on, give me a break.
I know.
So you did a BTL, but how'd you do it?
So these were the ones where I say BTL is postpartum, so an infraumbilical incision, and then doing the modified Pomeroy.
Okay, I would have probably said postpartum.
Oh, okay.
Postpartum sterilization. Let 'em ask
Instead
you.
of BTL?
Yeah, let them ask you how you did it.
So if I put postpartum sterilization, then, so it's not so redundant, probably on the first one I should put family planning?
Yeah, I think that's fine. Family planning, then write postpartum sterilization, and then bilateral tube segments. I think it's fine.
Okay, great, thank you.
Case number 12. Again, this is the same thing you have up above, so I would just make it a copy of number 11. Number 13. I think you'd use family planning for all these, or
I will.
you know, everybody desires. If you guys write down desires permanent sterilization, clue you in. There is not a permanent sterilization.
Right.
So then they'll say, well, oh, is that permanent? And then you'll play a game with them, trying to get the, you know, what do they mean by that? So I don't know. I like family planning, guys.
Okay,
but if you want to put down sterilization, I like it too. But I wouldn't say permanent. Just say sterilization.
Gotcha.
Okay.
And
So then you did a laparoscopic bilateral tubal sterilization. Let them ask you what type you did. Did you put a ring on? Did you use a bipolar? Did you use a unipolar? Did you use a Hulka clamp? What did you do? Let them ask you.
Okay.
They're going to know something, and then you're going to put in the surgical pathology normal anatomy.
Right. Bilateral tubal segments, yeah. Oh, normal anatomy, you're right, normal anatomy.
Normal anatomy. You didn't take out anything.
No, that's correct, yeah.
Okay. Case number 14, looks like it's going to be the same thing.
Yep, gotcha.
Okay, we're ready, Denise. Denise,
Dr. McSherry?
she's wandered away from us.
Oh, boy.
Well, let's see if I don't think she gave me it. No.
Dr. McSherry?
Oh,
Oh,
there she goes. There she goes. Okay, so
Sorry.
case number, that's okay. Case number 14 then is identical. Case number 15 is identical to the to above. Under that was that a postpartum on number 15?
No, that was, yes, it was 6 weeks postpartum.
Okay. So again,
Family planning, laparoscopic bilateral tubal ligation, and then normal anatomy.
yeah. Or you could have just said laparoscopic sterilization too.
Oh, okay. Yes,
And that way, again, you're going to be asked what you did.
Right. Good.
Okay. Just various ways you want to make it the same all through here, though. And everybody's going to make their list look like their list. Okay?
Right.
Okay. Again, I would have wrote in 40. Mirena IUD.
Oh, do not write the IUD?
No, I would. You can write sterilization, but I would, what's in first, I always put first. So I would have wrote Mirena IUD, and then sterilization. And then I would have put laparoscopic sterilization, removal of IUD.
Okay.
Number 17, again, I would have written family planning, and a postpartum sterilization, and then bilateral tubal segments. Number 18, sterilization. Again, either select sterilization or family planning and carry through so that they don't ask you, well, what's the difference between family planning and sterilization?
Okay.
And then, again, that was a postpartum?
Correct.
So you want to carry it through. If it's postpartum, you want to say postpartum sterilization or postpartum bilateral tubal ligation, or, you know, one or the other. And then your path report, I would have just said bilateral tubal segments just like you did before.
Okay.
Case number 19, ectopic, laparoscopic self-injostomy. Oh, good. They'll ask you the difference between self-injostomy and self-injectomy. Okay. And I don't think you have to say ectopic pregnancy tissue. I would just say immature placental villi, and that's all I would have written.
Okay.
Okay.
Okay, now there's a question here, Laurel, and I'm just going to send it out to everybody.
Okay.
It says, what do we do with high procedure counts? For example, I've done 18 ablations, 26 tubal ligations, etc. from one of the candidates.
Well,
What do you think about that?
what do I think about that? I would think that you better know how to describe it down to fine detail. Fine detail.
Should they list every single one that they do, though? I mean, do you just like cut down and put the two that are? I mean, that's a problem I get with people, candidates who are like attendings at residency programs, and they kind of supervise all the residents, and they do like 5 tubals on a Saturday and then 10 tubals on a Sunday. I mean, do they write, because they sign off on all the charts, and that's their case because they're billing for it, even though it's a Medicaid or...
If they didn't do the case and the resident was doing it and they were only explaining to the resident, I wouldn't put it on my list.
Okay. Okay, so but if you're...
But if I did it, I'd put it on my list.
Okay, that's all I wanted to know, because a lot of, and that's a question I get from a lot of people that are in residency programs.
The residents, if the resident's doing it, you're only supervising, and you may put your hand in there if they're doing something wrong, like to correct the way they're holding a clamp or to show them how to do one side and they do the other.
Right.
I probably would not put that on my list because you'll get a lot on there. But if you truly did the case and it's truly yours by yourself, I'd put it on there because they can get that if they went to look to see if you truly did the case.
Right.
Now, do I think they pull them? I really don't think they do, but my luck would be that I would be the one, if I left one off, that's the one I didn't put on and I'd get it for it. So if you didn't do it, I wouldn't put them on. A resident did it, I'd let the resident take it because you have enough cases probably anyway. If you're short on cases, though, oh boy, that's a tough one if you're short on cases. We rarely have somebody short on cases.
Yeah, and then somebody actually just sent me another text, too. They were concerned about it. I'm in a private practice and very GYN heavy. We did 27 hysterectomies as well. So do they need to list every single hysterectomy that they did?
If they did them, yes, they do. If they assisted someone, no.
Okay. Okay, that's all they wanted to do. And then somebody else sent me a text message. They do ask. They do ask. So I think it's important. Now, Laurel, are you available for private caseless construction over the phone? Are you available for that? I just wanted to, because I know you're really busy over with private practice.
Yeah, I can do it.
Okay, I just wanted to make sure. And then also we have a lot of other faculty members that are available. If Laurel's not available, she's busy. So, Laurel, I'm going to be sending you some people here and there for caseless construction, and then everybody else too. I just wanted to let you know, if you have we're trying to use Facebook more because a lot of people like to go to Facebook to see what other people are asking. So if you have a question about your case list on how to list something, Facebook it, because then I will respond, or Dr. Wall will respond, or one of our faculty will respond about Facebook. If you have a question, and then you can get it answer it very quickly, and then everybody else can see it too, if you don't mind doing that. But if not, you can just email me privately too. I'll answer simple questions. Laurel, thank you again, and thank you, Shelley, for being here too. I appreciate it, Laurel. Thank you so much, and I'll see you tomorrow night. Thank you so much. Okay, this is Dr. McSherry concluding tonight's webinar. It is 9:21 p.m. on June 17th, and we are done with the written webinar, so it's a pleasure now. Next month, we'll be starting at 9 o'clock p.m. Eastern Standard Time, so if you are on the West Coast and you're having a little bit of a problem, it's going to be 1 hour later now, and also for the people that are on the Mountain Time, too, it'll be a little bit easier, too, because it'll be at 8 o'clock as opposed to 7 o'clock. So it'll be easier for a lot of us. And take care, have a good night, and thank you all for being here. Remember, use Facebook for posting things. It's www.facebook.com and then OBGYN board prep. Please feel free to post any question you have, and then one of us will answer it. Some of our faculty are members of our Facebook page, and they will answer your Facebook question about caseless. So take care and have a good night, and thank you all for being here. I appreciate it. Thank you.